Hello guys, welcome back to Easy Medicine. Today we are going to discuss the topic bronchiectasis. So this is a third obstructive lung disease. We have already discussed bronchial asthma and chronic obstructive pulmonary disease. So let's briefly compare them. So the bronchiectasis is irreversible dilatation of bronchi and bronchioles due to destruction of smooth muscles and elastin due to chronic necrotizing infections. So what is happening here? Because of recurrent and chronic necrotizing infections, there is damage or destruction to the smooth muscles and elastin, and further that will result in the dilatation of bronchi and bronchioles because of the valve destruction. That is bronchiectasis. Note that the entire pathogenesis is structural damage and hence it is irreversible. Emphysema. Emphysema is also irreversible enlargement of respiratory bronchioles and alveolar sacs. Then we have another part of COPD, which is chronic bronchitis. This is chronic inflammation of trachea, bronchi and bronchioles, and chronic bronchitis has been defined as the persistent cough with sputum for 3 months in 2 consecutive years without any other cause found. Right, this is chronic bronchitis. So the emphysema and chronic bronchitis are the two different spectrum of the chronic obstructive pulmonary disease. And lastly, asthmatic bronchitis. The asthmatic bronchitis is a chronic inflammation of bronchi and bronchioles marked by reversible bronchoconstriction. That is the difference here. Asthmatic bronchitis is because of type 2 or non-type 2 inflammation, and it is also a kind of chronic inflammation but without significant structural damage to the airways, and hence the reversible bronchoconstriction. Now let's look at the definition. Of course, the definition is irreversible dilatation of bronchi and bronchioles. This can be focal or diffuse. So as shown in the image, the three arrows indicate three different kinds of morphologies, starting with the cylindrical one. The image itself is showing you the airway is dilated, but it is dilated uniformly all throughout. So this is a cylindrical or a tubular bronchiectasis. And then you have the second one. As you can observe, there are alternate constrictions and dilatations. This is varicose bronchiectasis, which gives an appearance of irregular beaded. And lastly, we have multiple cyst-like structures. This is a cystic bronchiectasis, and this is the most severe form. Now let's talk about the etiology of bronchiectasis. The focal bronchiectasis can be because of obstruction of the airway. The obstruction of the airway could be because of the foreign body or any mass or a tumor or lymph node. The enlarging lymph node because of this granulomatous inflammation and Mycobacterium tuberculosis can obstruct or can block the airway that can further result in this bronchiectasis distally. Second one, diffuse bronchiectasis. The causes are numbered. So starting with the infections, Mycobacterium tuberculosis reactivation and non-tuberculous mycobacteria. Of course, other bacterial infections can also cause like streptococcus and all, but importantly, the Mycobacterium tuberculosis reactivation will cause diffuse bronchiectasis, and lymph node tuberculosis will further result in obstruction and focal bronchiectasis. Immunodeficiencies like HIV and hypogammaglobulinemia, autoimmune conditions, rheumatoid arthritis, systemic lupus erythematosus, Sjogren's syndrome, allergic bronchopulmonary aspergillosis, all these are also the causes for bronchiectasis. Then recurrent aspiration will increase the risk of necrotizing infections, necrotizing pneumonias in the patient, and further increasing the risk. Idiopathic pulmonary fibrosis and post-radiation fibrosis. See, in this kind of situation where there are multiple collagen strands which have been laid out, the fibrosis contract with the eventual progression of time. So one of them will get enlarged and one of them will compress. I mean, if there are two alveoli on the two ends of the fibrotic string, one of them will compress and one of them will enlarge because of the tightening of the fibrotic strand. So that is what is called as traction bronchiectasis. We come across traction bronchiectasis when we talk about the interstitial lung disease. And then alpha-1 antitrypsin deficiency. Of course, this is a genetic cause, and the alpha-1 antitrypsin deficiency can cause both emphysema as well as bronchiectasis. Then it can be commonly associated with asthma or COPD as well. And the genetic causes. What are the genetic causes? Starting with the first one, alpha-1 antitrypsin deficiency. Number 2, cystic fibrosis. We have already discussed about cystic fibrosis. And 3, Carter-Jenner syndrome. Now comes 3 important syndromes which we need to remember, which includes a triad of features. Carter-Jenner syndrome, otherwise called as primary ciliary dyskinesia or immotile cilia syndrome. It is a triad of chronic sinusitis, bronchiectasis, and situs inversus totalis. As you can see in the image, here actually the heart should be to the left side, it is on the right side, and also the gastric bubble should also be on the left side, it is there on the right, it is there on the gastric bubble should be there on the left side, it is there on the right side here in this image. So there is inversion of the internal organs, be it the heart as well as the stomach as well as the liver. So this is situs inversus totalis. This is seen in 50% of cases of cardiogenic syndrome. And triad of chronic sinusitis, bronchiectasis, and situs inversus totalis is called as the cardiogenic syndrome or primary ciliary dyskinesia syndrome. Then you have Young syndrome. Young syndrome is a triad of chronic sinusitis, bronchiectasis, and azoospermia. Remember, even though he is young, he is not useful because he is having azoospermia. You can remember in that manner. Then you have yellow nail syndrome. Yellow nail syndrome is a triad of respiratory tract infections or bronchiectasis or pleural effusion, that is one point, and the other two are yellow nails and lymphedema. So as you can see in the image, the discoloration of the nails you can appreciate. The nails of the upper hand, I mean the nails of the hand as well as the nails of the foot are also in yellowish color, and you can also appreciate the edema here. So this is lymphedema along with the yellow nails. So the triad of recurrent respiratory tract infections or bronchiectasis or pleural effusion along with yellow nails and lymphedema is called as the yellow nail syndrome. Now, having understood these etiologies, now let's see which etiologies involve which part of the lungs. So we broadly divide the bronchiectasis into upper lung field predominant bronchiectasis, mid lung field, lower lung field predominant bronchiectasis, and lastly central airway predominant bronchiectasis. The upper lung fields are prominently involved in cystic fibrosis and post-radiation, whereas the mid lung fields are prominently involved in Mycobacterium avium complex or Carter-Jenner syndrome. Then lower lung fields are commonly seen with chronic aspiration, and aspiration is predominantly seen when there is dysphagia and esophageal regurgitation that can be associated with systemic sclerosis or scleroderma. And then traction bronchiectasis, Young syndrome, and hypogammaglobulinemia. Lastly, central airway predominant bronchiectasis can be seen with allergic bronchopulmonary aspergillosis, William Campbell syndrome, and Meunier-Kuhn syndrome, otherwise called as tracheobronchomegaly. See, this can be remembered by using this simple visual mnemonic here. That's why I put up these images. So look at the first image. Imagine there is a lung standing and over which the sun is shining on it. And because of the sun, the lung is sweating out. Okay. So if you remember this simple story, because of sun, we understood radiation, and because it is sweating, the sweat chloride concentration is the investigation of choice for cystic fibrosis. So cystic fibrosis is also a cause for upper lung field bronchiectasis. And you can see in the middle, in the mid lung field, you can appreciate a cart which is filled with the Big Macs, the McDonald burgers, right? So the cart standing for Carter-Jenner syndrome and burgers from McDonald's standing for MAC. So the cart with burgers are located in the mid lung fields. And when you look at the central airway, understand this image, there is a camp of lungs which have come together, and in the center there is a lung which is mourning and saying Abba. Okay, so this is a camp, William Campbell syndrome, and in the center, that is why it is a central airway, and it is mourning, that is why Meunier-Kuhn syndrome, and it is saying Abba, that is why it is ABPA. Hope this is useful in some way. I know it is, this is little childish, but it's okay. Pathogenesis. So this entire vicious circle of bronchiectasis keeps on happening again and again, but there should be a trigger, right? So the initial trigger could be a bacterial infection, or increased susceptibility to bacterial infections can also be there in the patient, or there could be cystic fibrosis or dyskinetic cilia. Either of them can result in defective mucociliary clearance. Defective mucociliary clearance will increase the risk of infections. So recurrent respiratory tract infections, non-tuberculous mycobacteria, Pseudomonas, Burkholderia, and of course other infections like staph, strepto, moraxella, haemophilus also can be there here. The infections with these organisms will result in colonization and biofilm formation. And the colonization and invasion of the airway tracts can result in this chronic inflammation, and the chronic inflammation will impact both the larger airways as well as the smaller airways. When the smaller airways are filled with inspissated secretions, thick tenacious secretions, what will happen? They will get blocked and this patient will have small airway obstruction. And large airways will also get blocked. They'll not be blocked easily, but the lumen is reduced, and the large lumen is also filled with significant amount of secretions, and that is why the patient will have cough with purulent sputum. Of course, because of chronic inflammation, there can be bronchial dilatation and tissue destruction as well. And when there is tissue destruction and bronchial wall damage, what will happen? The mucociliary clearance worsens further, and that will further increase the risk of bronchiectasis again. This is a vicious cycle of pathogenesis of bronchiectasis. This is an image showing the pathological changes that have happened. So this is a gross image. As you can observe, the airways are significantly dilated with the deposition of purulent secretions inside. And here is a normal airway with the thin mucus layer and clearly visible cilia, and here is a columnar epithelium, and you can see the intact wall all throughout. And this is an image of the bronchiectatic airway where there is defect in the bronchiolar or bronchial wall, and there is also significant amount of mucus, and there is loss of cilia. Okay, so that is how a bronchial wall in bronchiectasis would be. Now, what are the clinical features? Let's start with the symptoms. The most predominant symptom is cough. The patient will have cough with copious amount of sputum, and the sputum is also thick and tenacious. It is foul smelling and commonly associated with hemoptysis, because the bronchial wall damage can also result in damage to the vasculature that can increase the risk of hemoptysis. Rarely, this can also cause massive hemoptysis, which can compromise the hemodynamic status of the patient as well. Then the patient will have dyspnea. Pleuritic chest pain may or may not be seen. It can be seen only when it is underlying the pleura. Then on examination, on auscultation, you will find coarse crackles and wheezing because of the small airway obstruction, and coarse crackles is because of the air bubbling in and out of the thick tenacious secretions. And clubbing can be seen in all the suppurative lung diseases like lung abscess, bronchiectasis as well. Now, the initial test for diagnosis will be a chest X-ray, but the investigation of choice will be a CT scan. This image is showing you a lot of findings. So here, what you can observe is the tubular structures are present just beneath the pleura as well. In a normal lung, they are not usually present. Within 1 centimeter of pleura, these tubular structures will not be visible. The airways will not be visible. But if they are present even in the 1 centimeter beneath the pleura, that is what you call it as lack of bronchial tapering. That can be seen with bronchiectasis. Then here you can see a tube-like structure, that is of course tubular bronchiectasis, and it is also called as a tram track sign. Tram track sign that is indicated by dilated bronchi. Parallel tram tracks indicate dilated bronchi, and here is a tram track. And you can see there is a ring-like structure. This is nothing but a cross section of the tubule that we have seen. A tubular bronchiectasis, when it undergoes cross section, that's how it will appear, and it is called as a signet ring shape. So the cross sectional diameter should be 1.5 times more than the diameter of the adjacent vessel. That's when you say it is a signet ring, right? So this is another structure, another radiological feature of bronchiectasis. What you can see here is a tree in bud appearance. Actually, there is no tree in the bud. The actual description is a branching tree, and over which there are buds which are located. That is what is being metaphorically mentioned as tree in bud appearance radiologically. And the prominent tree is because of the bronchus, which is having thickened walls and also is filled with inspissated or thick secretions inside. And the buds are because of the alveoli, which are again filled with thick fluid. Now you need to send for the sputum for gram stain, AFB, and culture sensitivity. If the patient is having diffuse bronchiectasis, he will obviously produce significant amount of sputum, which we can send for sampling. But if the patient is having focal bronchiectasis, the patient will not generate sputum, but even though there is pathology inside. So you need to do bronchoscopy for removing the foreign body or to relieve the obstruction, or also to take the sample out. Okay, so if you are suspecting allergic bronchopulmonary aspergillosis, send the sample for fungal hyphal elements as well as eosinophil count in the sputum. That will give us the clue towards allergic bronchopulmonary aspergillosis. Then let's look at the treatment. The treatment is with the antibiotics, anti-inflammatory drugs and bronchodilators, of course bronchial drainage procedures. Let's start with the antibiotics. Start empirically because you have the suspicion of the common organisms like Streptococcus, Haemophilus influenza and Moraxella. Of course, the Burkholderia cepacia and Pseudomonas are very virulent and that will significantly damage the airways, but the common organisms can be Streptococcus, Haemophilus and Moraxella. For covering them, start with the levofloxacin, amoxicillin clavulanate and third generation cephalosporin. Any of these three can be given. If you are suspecting Pseudomonas, then add ciprofloxacin or piperacillin tazobactam. If you are suspecting non-tuberculous mycobacteria, the regimen would be macrolide plus rifampicin or ethambutol. And if you are suspecting allergic bronchopulmonary aspergillosis, then the treatment regimen would be itraconazole and usage of steroids. So depending upon the organism, we can adjust the treatment regimen. But even though you have started the patient on empirical antibiotic therapy, we have already sent for the gram stain and culture sensitivity. Eventually, after 48 hours, you will get the culture sensitivity report. Depending upon the culture sensitivity report, you can obviously change the antibiotic regimen as well. Then the anti-inflammatory drugs. The anti-inflammatory drug that we use is inhaled or oral IV glucocorticoids in allergic bronchopulmonary aspergillosis or pre-existent or coexistent COPD or bronchial asthma. Then bronchial drainage. Bronchial drainage means, see, the patient's airways are dilated and the patient is not able to cough out the sputum, and hence we need to do this bronchial drainage procedures to drain the bronchi of these secretions. So the bronchodilator nebulization with short-acting beta agonist or long-acting beta agonist or muscarinic antagonist would be helpful here. And the mucolytics. The mucolytics are specifically used in cystic fibrosis related bronchiectasis. Of course, the simple mucolytics like N-acetylcysteine as well as ambroxol can be used in all cases of bronchiectasis, but specifically DNase or Dornase. Dornase is also a recombinant DNase. This is helpful in breaking down the thick tenacious secretions in cystic fibrosis related bronchiectasis. And you have multiple maneuvers in chest physiotherapy. I'll just name them: mechanical chest percussion and postural drainage, high frequency chest oscillation, and oscillatory pressure expiratory flutter valve. So these are certain maneuvers which are useful in the management or the bronchial drainage in the part of physiotherapy. Now, how do you want to prevent them? You have already treated an episode of bronchiectasis. You further want to prevent the episodes of bronchiectasis because the patient is already having increased susceptibility with the dilated and enlarged airways. The prevention would be usage of rotating schedule of antibiotics for certain duration depending upon the antibiotic. So we'll start with the ciprofloxacin. Ciprofloxacin can be used 1 to 2 weeks in a month. You can also use macrolide where it can be used daily or 3 days a week, and tobramycin inhalation with 30 days on and 30 days off can also be used. And don't try to use the same antibiotic all throughout the time, all throughout the year. You want to use the rotating schedule of antibiotics because you don't want to increase the risk of resistance in the patient. That is about the bronchiectasis. Lastly, let's look at the cystic fibrosis. Cystic fibrosis is an important cause of bronchiectasis in infancy and childhood. So it is an autosomal recessive condition and the onset is commonly in neonate to childhood. What is the protein that is defective here? Cystic fibrosis transmembrane conductance receptor is the protein that is defective here. It is an anion channel which transfers chloride and bicarbonate. The transport of chloride and bicarbonate on the apical membrane is carried out by this protein, and it is a 14 not 8 amino acids are located in this molecule. And the protein is encoded by a gene named as CFTR, which is located on chromosome 7. And in regard to CFTR gene, 1600 mutations have been identified. Among them, some hundreds are pathogenic. And among all the mutations, the most common one, which accounts for 70% of cases of cystic fibrosis, is F508 deletion, and the next common one is G551D mutation. So these two are the most important mutations in the pathogenesis of cystic fibrosis. What are the organisms causing bronchiectasis here? Again, Pseudomonas is most common. Of course, you can also see Staph, Strepto, and Haemophilus, Moraxella. All the organisms can also be seen commonly. Now let's look at the pathophysiology of bronchiectasis. See, if there is a normal cystic fibrosis transmembrane conductance receptor protein. I told you it is an anion protein, and as you can appreciate in the image, the CFTR is going to allow the chloride and bicarbonate into the lumen. What kind of lumen it could be? It could be a pancreatic duct, it could be a hepatic duct, it could be intestine, it could be the airway. So wherever there are lumens which are filled with mucus, the normal consistency of the mucus is to be maintained with the help of this CFTR protein, because it will infuse chloride and bicarbonate into the lumen, and following them the water will also passively move into the lumen, making the secretions thin, right? That will result in a normal or a free flow of thin mucus inside the tracts. So CFTR is involved in the secretion of chloride and bicarbonate rich fluid into the all lumens, and that will passively allow the water to come along, and that will maintain the normal flow of mucus. This is on one hand. On the other hand, CFTR is also useful for reabsorption of chloride from the sweat glands. So you have the sweat glands over your skin, right? So the CFTR is useful for reabsorption of chloride. This is a normal function of CFTR. What if the CFTR becomes defective? So when the CFTR has become mutated, as you can observe, the chloride and bicarbonate entry into the lumen is reduced. So the passive flow of water is also reduced. Then what will happen? Whatever the secretions that are located in the lumen will become quite thick. So because of this high viscous secretions, there is reduced ciliary movement, and there is eventual blockade of these lumens. On the other hand, because the CFTR is involved with the reabsorption of chloride, the reabsorption of chloride is defective, and the sweat contains significantly high levels of chloride. So the sweat chloride concentration is increased in these patients. That is about the pathophysiology of cystic fibrosis. Now let's look at the clinical features. The cystic fibrosis can involve multiple parts of the body and multiple systems. So let's start with the sinuses. The high viscous secretions is the main reason, and the patient will have chronic sinusitis. In regard to the lung, the patient will have COPD and bronchiectasis. In regard to the liver, the patient can have bile duct obstruction and fibrosis that can eventually result in cirrhosis and portal hypertension. And in regard to the pancreas, there is pancreatic duct obstruction and fibrosis. Of course, that will result in chronic malabsorption. And so when the pancreas undergoes atrophy or fibrosis, the patient will have both exocrine pancreas deficiency and endocrine pancreas deficiency. Exocrine pancreatic deficiency will result in malabsorption in the patient with steatorrhea, whereas endocrine pancreatic deficiency will result in diabetes in the patient. And intestinal secretions, when they become quite thick, the child will develop meconium ileus and the ileal obstruction. And the males, where there is vas deferens, which is also a lumen, it is also getting blocked, and the patient will have infertility. Remember, 99% of males are infertile when the patients are having cystic fibrosis, and the patient will also fail to thrive because of all these problems. Hope you understood the clinical features. Now let's look at the diagnosis. See, the diagnosis can be made out even in the newborn, right? The newborn screening for CFTR can be made, and if it is positive, the investigation of choice would be to uh, look at the sweat chloride concentration. It is the gold standard investigation. That is in the newborns. Even in if you identify cystic fibrosis features in an adulthood or childhood, the cystic fibrosis patients very rarely come into the adulthood. It is commonly diagnosed in childhood itself. And if you suspect cystic fibrosis even in childhood or adulthood, the next investigation is to do pilocarpine iontophoresis. See, the pilocarpine iontophoresis means you will put, as you can see in the image, here is the apparatus where the charge is being delivered to these discs. This apparatus contains a pilocarpine disc on which the electrodes give some electric current. Because of this electric current, the drug infused discs will transfer the drug from the disc into the skin. Okay, so this electric current will help in the infusion of drug into the skin, and when the pilocarpine enters into the skin, that will increase the production of sweat. So in sweat, you will estimate the sweat chloride concentration. This is the gold standard for the diagnosis of cystic fibrosis. And when it is more than 60 millimoles per liter, it confirms the diagnosis of cystic fibrosis. If it is less than 60 mole per liter, then you should do genetic analysis or nasal potential difference for further confirmation of cystic fibrosis. Lastly, let's look at the management. So now we have CFTR modulators, CFTR gene modulators. So they are ivacaftor, tezacaftor, and elexacaftor. These are the CFTR modulators. If you use 3 of them together, it is a triple combination therapy. And there is another new drug which is a lumacaftor. And if the patient is not responding to any of these CFTR modulators, then the lung transplantation is the ultimate choice for the patient. So this is about bronchiectasis. Hope you like this video. If you like this, please share this with your friends and subscribe to this channel. Thank you.